रिकॉर्डिंग शुरू थी भैया? Bismillahirrahmanirrahim. Today topic is the immunosuppressants or immunopharmacology 1 and 2. I will take both lectures in the one sitting due to some theoretical problems and rearrangement of the schedules. So immunopharmacology or immunosuppressant drugs. Objective of this lecture is to understand the immunity role in our body. Now the classes of drugs which are used as immunosuppressant agents, mechanism of action of the drugs, their major uses, adverse effect, and notable pharmacokinetic parameters. Understanding the rationale of the treatment, schedule, and combination therapy. Understanding the limitation of the therapy of the immunosuppressant drugs. Along the purpose of this is also to motivate the student to become a self-learner so that they do not need the help of any other person except the books. So self-learning is also the one of the main objective for today's class. Overview of the immunopharmacology. As you all know that the immune system is an important protective system of the body, our body, against the harmful foreign molecules or tissues. But it is one of the most complex organ system in the body, which can make it difficult to manipulate because so many functions, defense mechanisms are concerned with immunity system. Whereas the immunosuppressant drugs reduce the activation or efficacy of the immune system of the body for to treat the certain conditions such as the autoimmune diseases or to lower the body ability to reject a organ transplant, life-saving procedures. As you know that autoimmune disease means sometimes some tissues which are not exposed to the circulation or body to the immunity system, but due to some injury to that particular tissue like the joint, like to the lens of the eye, the protein of these areas come in contact with the immunity system of the body, and then they recognize that that is not our own body protein. Therefore, they produce the immunity against these type of the diseases they are called the autoimmune diseases. The goal of treatment for these diseases is to stop this inappropriate and harmful process of the immunity, which can last to the human body or to the procedures. Just like, for example, in case of the organ transplantation, foreign tissue is purposely implanted into the recipient, but the goal remains the same, to use the drugs therapy to limit the damaging inflicted by the immune system and the potential rejection of the transplanted organ. Just like transplant liver, kidney, heart, they are now commonly kidney transplant, liver transplant, commonly procedure. Also, the heart transplant are occurring in the developed countries. And commonly, the transplant of the cornea of the eye was the common procedure which is adopted frequently in the various areas of this country, also somewhere else, and there is no any specialized expertise are required for transplant of the cornea. Earlier drugs were non-selective and patient frequently stable to infection due to suppression of both the humoral as well as cell-mediated immune system. But nowadays, with the advancement of the technology, the principal approach or target of the immunosuppressive drug is to alter the specific lymphocyte function using drugs or the antibodies against human proteins specifically. But due to toxicity of these compounds, usually we prefer the combination of the drug therapy in the lower dose to minimize the adverse effect of these drugs. Therefore, multiple drug therapy is usually given in the organ transplant conditions or procedures. Immunosuppressive drugs regime typically consists of 2 or more agents with different mechanism of action that disturb the various level of the T cell activation of in the organ transplant condition is the different mechanism of action, different group of the drugs used with the different mechanisms so that we can get the maximum benefit and minimum loss or adverse effect to the patient. And also we can use monotherapy like the cyclosporin may be useful in the treatment of psoriasis, and various other monoclonal antibodies have been application in the number of disorders just like rheumatoid arthritis, multiple sclerosis, systemic lupus erythematosus, Crohn's disease, and the ulcerative colitis like conditions. The drugs which are used as an immunosuppressant, they are divided in different groups depending on that. One group is the antibodies group. That is a elmituzumab, anti-thymocyte globulins, basilimab, and the rituximab. These are the antibodies produced against some specific proteins. Where another group of the drugs is a calcium inhibitors like cyclosporin, tacrolimus. Where the third group of the drug is the co-stimulation blockers like belatacept compounds, whereas a fourth group of drug is the mTOR inhibitors, mammalian target of the rapamycin inhibitors, whereas the everolimus and the serolimus are the drugs which are mTOR inhibitors. mTOR inhibitors are mTOR inhibitors. Whereas another group of the drugs also used as immunosuppressant like the anti-proliferative agents like the azathioprine, myclophenolate, mofetil, and the myclophenolate sodium. These are the preparation of the myclophenolate compound. Whereas a commonly, most frequently, and widely used since long time, the adrenocorticoids preparation like the methylprednisolone, prednisone, which are the corticosteroid already completed in the previous lectures. Corticosteroid, they are also used as a immunosuppressant, and they have a lot of the clinical applications along the lot of the clinical side effects. Prolonged use can cause the inhibition of the adrenocortical axis, which can cause the depletion of the adrenocorticoid. Therefore, their treatment requires a special precaution and a special way of the reducing the therapy slowly and gradually to get the maximum benefit, minimum loss to the patient. Other group of the drugs which are used as immunosuppressant are the bortezomib and also immunoglobulins. They are also used as a immunosuppressant agents. So drugs are the immunosuppressant antibodies, calcium inhibitors, mTOR inhibitors, and the corticosteroids. Whereas related the immunosystem, immunoactivation cascade can be described in 3 signal modules. For example, signal 1, signal 2, signal 1, signal 2, and the signal 3. In the signal 1, which constitutes T cell triggering of the CD3 receptors complex, by an antigen on the surface of antigen presenting cells. Signal 1 alone is insufficient for activation of the T cell production. Therefore, it requires the help of the signal 2. Therefore, it is also called the co-stimulation signals. Signal 2 also referred to the co-stimulation signals occur when CD80 and the CD86, also known as the B7.1 and the B7.2, on the surface of the antigen presenting cells, engage CD28 on the T cells. Both signal 1 and signal 2 activate several intracellular signal transduction pathway, one of which is the calcium calcirinium pathway. These pathways trigger the production of cytokines like the interleukin 2. Whereas in the signal 3, interleukin 2 then bind to the interleukin 2 receptors, also known as CD25, on the surface of the other T cells, and then thereby providing signal 3, activating the cell cycle via mammalian targeted of the rapamycin through mTOR and leading to the T cell proliferation and production. This diagram shows the summary of the previous slide, that due to the CD25, which are antigen presenting cell, signal 1 can cause the activation of the T cell receptors presenting in the resulting in increase the intracellular calcium, whereas also activation of the calcirinium, a calcium-dependent phosphatase enzyme, which can lead to the activation of this calcirinium. This activation can lead to the activate the NF50 and activate NF50 associated with the other molecular component, leading to the activation of gene encoding cytokinins. Normally, this gene and encoding cytokinins can lead to the production of the interleukin 2 messenger RNA. This interleukin 2 messenger RNA can lead to the production of the interleukin 2, which can be release of the interleukin 2 will be occur. This interleukin 2 then bind to the receptor and start the signal 3 mechanism, which activate the mTOR, and this mTOR can lead to the act on the cell cycle and lead to the production of the T lymphocytes or T cells. Whereas drugs like the tacrolimus and cyclosporin can block this pathway activation or formation of the calcirinium. Therefore, they are called the calcirinium inhibitor drugs. Whereas mTOR is inhibited by the everolimus and the sirolimus. Therefore, they are called the mTOR inhibitor drugs. Whereas another group like the belatactin block the interleukin through and the CD4 conversion. They are called the signal 2 blocker drugs. So these are the main mechanism how the T cells or interleukins 2 are produced and how they can be helpful in the production of the T cell cycles, T cells from the cell cycle, and what are the sites where the drugs can be inhibit the production of the interleukin 2. Immunosuppressant can be broadly also categorized by their place in the therapy and mechanism action. One is the induction therapy, other one is the maintenance therapy. Induction therapy is a acute therapy started in the initial phase, where maintenance therapy, as the name indicates, is used for the longer duration for maintenance of the normal condition and inhibiting the rejection of the transplant for longer duration. So induction therapy are more potent immunosuppressant drugs such as the monoclonal antibodies, polyclonal antibodies, often used in induction therapy, which powerfully suppress the immune system at the time of the transplant. allowing the new organ to start functioning in the recipient and preventing early graft rejection. Whereas the maintenance therapy is a group of the immunosuppressor drugs on the other end are less potent and provide long-term immunological protection for the transplanted organ, which lower the risk of the infection than with the induction therapy of the drugs. So induction therapy and the maintenance therapy is also the part of the immunosuppressive drug therapy. Induction and rejection immunosuppressive medicine are used of the antibodies play a central role in prolonging the allographic survival. Means if tissue transplant is from one person to the another who is not genetically identical. Antibodies are prepared by immunization of the either rabbit or horse with human lymphoid cells, producing mixture of the polyclonal antibodies or monoclonal antibodies. Our antibodies can be produced by the hybridoma technology, in which we producing the antigen specific monoclonal antibodies. Hybridoma are produced by fusing mouse antibody produced cell with the tumor cells. Whereas in the hybridoma, hybrid cells are selection and colonized, and the antibody specifically colonized is determined. Colonies of intestate can be cultured in the large quantity to produce clinically useful amount of the desired antibodies. Whereas another way of the producing of the antibody by recombinant DNA technology can use to replace part of the mouse gene sequence with human genetic material, thus immunizing the antibody and making them less antigenic. Whereas the drugs used for this purpose is the anti-thymocyte globulin or polyclonal antibodies produced by isolating gamma globulin fraction of the serum obtained from the rabbit or horse after immunization with human thymocytes. Anti-thymocyte globulin cause depletion of the circulating T cells and apoptosis of the activated cells. Programmed cell rate of the activated cells increase and also cause the depletion of circulating T cells. Rapid preparation are preferred over the horse preparation because of greater potency and less toxicity as compared to the horse production. Anti-myocyte globulin rabbit is primarily used for the time of the transplantation to prevent early allographic rejection along the other immunosuppressive agents, whereas it may be also used to treat the severe rejection episode or corticosteroid resistant patient rejections. Anti-thymocyte globulin usually used for 3 to 10 days to produce profound lymphocytopenia that may last for a year. Whereas the anti-thymocyte globulin antibodies are slowly infused IV and their half-life is extended 3 to 9 days. Whereas the pre-medication with corticosteroid, antipyretic, antihistaminic drugs may be helped to reduce the infusion-related reaction of the anti-thymocyte globulin antibodies, where a prolonged use may be associated with a profound immunosuppression and increase the risk of the opportunistic infections and post-transplant lymphoproliferative disease. Post-transplant lymphoproliferative disease, which is also short word PTLD, post-transplant lymphoproliferative disease. Where the Basilix-MEB is a murine human monoclonal antibodies bind to the alpha chain of the interleukin-2 receptor, that is also called the CD25 on the activated C cells. Blockage of the CD25 receptor foul the ability of many antigenic stimulus to activate the T cell response system. Basilix-MEB used for prophylaxis of acute rejection in renal transplantation in combination with the cyclosporin and corticosteroid. This besilumab drug may be beneficial in those with delayed graft function and reduce the risk of the calcarein inhibitor associated renal toxicity in the renal transplant patient. Whereas besilumab is not T-cell depleting. Therefore, it is mainly used in induction protocol as opposite to the treatment of the rejection. Given by intravenous infusion, there is a serum half-life around about 7 days. Usually 2 doses of this drug are administered. The first at the 2 hours prior to the procedure, and second is 4 days after the procedure. The drug is generally well tolerated, whereas another group of the drug is the elizumab. It is also the humanized monoclonal antibody that bind to the CD52 on both T cells as well as on B cells, resulting in the depletion of both lymphoid cell lines. Depletion of T cell and B cells is observed soon after infusion, and recovery of these cells is gradual. T cell recover over 6 to 12 months, whereas the B cells recover around about 6 months or less. It is approved for the treatment of chronic lymphoid leukemia, but has been used in the transplantation as an induction and anti-rejection agent for both acute cellular rejection or antibody-mediated rejection. Antibody-mediated rejection means antibody-mediated rejection, AMR, due to its activity against the both T cells and the B cells. With the elizumab is also recommended for initiate or continuous prophylaxis for the pneumocystis pneumoniae, multiple sclerosis, and herpes simplex virus infection. Another group of this is a antibody retromazep, retrozimab. It is a chimeric monoclonal antibody against the antigen CD20 on pre-B cells, mature B cells, and memory B cells. Causes B cell depletion by inducing B cell lysis and blocking B cell activation and production, and eventually maturation to antibody-forming plasma cells. Existing plasma cells do not express the CD20 antigen. Drug is approved for use in the treatment of B-cell lymphomas, PTLD, post-transplant lymphocytic disease, and the rheumatoid arthritis. The benefit of using of this drug in the transplant is for antibody removal, which has been utilized by ABO blood group incompatible transplant desensitization protocol and treatment of the antigen-mediated rejection or reactions. With a rituximab given by the intracellular lead to the rapid and sustained depletion of B lymphocyte, with the B cell count returning to normal within 9 to 12 months. Rituximab has a box warning for reactivation of the JS virus, leading to the progressive multifocal leukoencephalopathy, which has been reported in the non-transplant population. Therefore, rituximab should be used with the caution with the virus infection, and which can lead to the multifocal leukoencephalopathy. Activation of the hepatitis B infection also been reported following treatment, and the hepatitis serology should be monitored during the use of the rituximab drug, because it can cause activate the virus, which Chepsoni virus, and other virus which can be aggravate the condition of patients suffering from the viral infection. Bortezomib is proteasome inhibitor that lead to the cell cycle arrest and apoptosis of normal plasma cells, therefore decreasing antibody production in sensitized patient. Whereas, whereas antibody-mediated reaction or rejection involve the production of high level of antibodies by plasma cells, either newly made from B cells or from those exit prior to the. One mechanism of control of the antibody-mediated reaction or rejection is to target antibodies production by plasma cells. Another group is the bortezomib, approved for the treatment of multiple myeloma, but it has been adopted for use in the treatment of the antibody-mediated reaction or rejection in transplant patient. It can be administered by IV bolus or subcutaneous injection, so it has a low potential for infusion-related reaction. Mainly metabolized by the cytochrome P40 enzyme, therefore hepatic dysfunction can be occur, which can be required the monitoring of the liver function during the therapy of the bortezomib. Another group of the drugs is the immunoglobulins, which are given through the intravenous route contain the. They are prepared by human plasma pool from many donors. It has an immunomodulating effect. It is often used for autoimmune disease, pre-transplant desensitization protocol, and the treatment of the antibody-mediated reaction. Immunomodulating effect on B cells and the T cells occur at the high doses, and is also used to lower the dose to prevent the infection by replacing immunoglobulin removed during the plasmapheresis. Immunoglobulins mechanism not well known, but in high doses, immunoglobulin appear to be induce B cell apoptosis and modulate B cell signaling. It has been inhibit binding of the antibodies to the transplanted graft and activation of the complement system. Half-life of the immunoglobulin around about 3 to 4 weeks. Where the adverse effect related to the immunoglobulin include the immediate headache, fever, chills, myalgia, and hypertension, which can be minimized by the giving the antihistaminic drugs, antipyretic drugs, and corticosteroid, but they can be caused the serious adverse effects, which are rare but can cause the like the aseptic meningitis, acute renal failure, and thrombotic event can be occur as a serious side effect of the immunoglobulin, but these are the rare ones. This is a summary of the drugs like the elizumab is a humanized monoclonal antibodies bind to the CD2052 on B and T cells, causing the T and B cell depletion. With the anti-thymocyte globulin, or the polyclonal antibody, cause the T cell depletion. With the beximab is a monoclonal antibodies bind to the CD25 and enable the interleukin-2 mediated T cell proliferation. Whereas the bortezomib is a proteasome inhibitor, inhibit the proteases, lead to the plasma cell depletion. Whereas the immunoglobulin, they are the antibodies against the B cells with the methyl corticosteroid are non-specific interleukin and tissue necrotic factor inhibitors. Where is a monoclonal antibodies acting on CD20 and also to the B cell depletion. Whereas they are used for the induction and treatment of the rejection, they are used for the induction purpose mainly, where these are the side effect, main side effect related to these type of the drugs. Like methyl progesterone, commonly used corticosteroid, they can cause hypertension, high low density lipoprotein, hyperglycemia, peripheral edema, mood disturbance, osteoporosis, weight gain, and chronic use can cause the moon sapefish and buffalo hump. So these are the side where the dictamab can cause the infusion-related chills, fever, infection, reactivation of hepatitis, megalovirus, cytomegalovirus, other virus, and fungus can cause the leukopenia, thrombocytopenia, myocutaneous reaction can be occur with these type of the drug. Whereas a bicillin is a monoclonal antibody well tolerated drug as compared to the other antibodies. With another group of drugs are the, which are used mainly for the maintenance immunosuppressant medication. For the maintenance purpose, intend to provide adequate immunosuppression to prevent allograft rejection while minimizing infection, malignancy, and drug-inducing adverse events. Often they are combined in regime with two or more drugs, using medication with a different mechanism of action, minimize drug toxicity. These drugs, which are mainly used for the maintenance, they are classified into four groups. One is a calcineurin inhibitors like the cyclosporin, tacrolimus. Second one is co-stimulation inhibitors or blocker, belatacept. Third group is a mTOR inhibitors like the sirolimus, everolimus, and fourth one is the anti-proliferative drugs like the mycophenolate and the azathioprine, and fifth one is the corticosteroid, which can be also used for the maintenance therapy. So corticosteroid can be used for the maintenance therapy. Corticosteroid can be used for acute rejection, antibody-mediated reactions or rejections. So corticosteroid, fifth one drug, which can be also used in the maintenance chemotherapy. So this was the part one. Any question from any student? Any question from any student? Any question? Any student have any question? Are you hearing me? Any student, if you have any question up to now?
No, sir.
Acha, bete. So we are continuing further. Maintenance therapy and the drugs already divided in the 5 groups. One is the calcineurin inhibitors, that is the cyclosporin, tacrolimus. Second one is a co-stimulation blockers, belatacept. Third one is a mTOR inhibitors, sirolimus and the everolimus. And the fourth one is the anti-proliferative drugs, mycophenolate and the azathioprine. And the fifth one is the corticosteroids. One group of first group of the drugs. Calcineurin inhibitors, cyclosporin. Cyclosporin and tacrolimus are drugs which are belonging to the group of the calcineurin. Both belong to the signal transduction through the calcium calcineurin pathway, already shown in the previous figures. Calcium calcineurin pathway, which is responsible for the formation of the enzymes activation, which can cause the formation, act on the DNA and cause the formation of the messenger RNA. Calcineurin, a calcium-dependent protein phosphatase, dephosphorylate nuclear factor of the activated T cells, that is NFAT. Along NFAT to enter the T cell nucleus and bind to the DNA, leading to the transcription and production of cytokines interleukin 2, where cyclosporin bind to the cyclophane, where the tacrolimus bind to the protein called the FK binding protein, where the mechanism of action of both cyclosporin and the tacrolimus is the same finally, but cyclosporin bind to the cyclophane, whereas the tacrolimus bind to the protein, especially called the FK binding protein. Tacrolimus is the preferred calcineurin inhibitor due to its decreased rate of the allograftic or transplant rejection as compared to the cyclosporin. although it is approved for the renal, liver, and heart transplant. Tacrolimus is the mainstay for the maintenance of immunosuppressant for all solid organ transplant. SOT, solid organ transplant, or SOA, solid organ allograft. So tacrolimus is indicated for the all the solid organ transplant or allograft. Calcium inhibitor also block the signal enzyme cytochrome 3A4, cytochrome 3A5, and P glycoprotein expressed in the GIT and liver. Therefore, due to the modification of these enzymes, they can modify the metabolism of the other drugs. Therefore, dosage titration is based on the 12-hour through rough level with gold through tot level varying between the different organs time from transplant and transplant center specific protocol. So monitoring of these things, titration of dosage is essential, and it is very on the patient transplant time and also by the protocol, specific protocol of the particular hospital. One of the primary limitations to use of the calcium inhibitor is the nephrotoxicity. So commonest side effect of the cyclosporine and tacrolimus is they can cause the nephrotoxicity. As with all immunosuppressant, infection are possible with the use of the calcium inhibitor, and the recipient are often given prophylactic medication after post-transplant. Whereas another side effect related to the cyclosporine that it can cause the hirsutism or excessive hair growth is a common adverse effect. Along the nephrotoxicity, it can cause the hirsutism, which is a side effect of the cyclosporine, whereas the tacrolimus do not cause the hirsutism, but it can cause the nephrotoxicity. So that is the difference between calcium and cyclosporine and tacrolimus, that hirsutism is caused by the cyclosporine. Another group of drugs is the co-stimulation blockers. That's a belatacept. Belatacept is a second generation compound which acts as a co-stimulation blockers, which is related to the blocking of the antigen represent cell surface markers or proteins like CD80 and CD86, which is further converted into the CD28. Co-stimulation blockers are recombinant fusion protein of the CTLA4 with CD28 bind to the CD80 and CD86 on the antigen presenting cells and preventing the formation of the CD28 from binding to these molecules, and thus inhibit signaling 2 pathway for the T cell activation, because for activation of the T cells, signal 1 pathway and signal 2 pathway are essential, where the signal 1 pathway can be easily stimulated as compared to the signal 2 pathway. Where the belatacept is approved for kidney transplantation, approved for Lareb. You have any problem? Bete? Lareb 211. Belatacept is approved for kidney transplantation in combination with the bexlimab, mycophenolate, mofetil, and the corticosteroid. This drug can substitute for the calcium inhibitor to avoid the determinal long-term nephrotoxic property, cardiovascular, and the metabolic complication seen with the cyclosporine and the tacrolimus. Whereas the first generation of the co-stimulation blocker is abatacept, and it is mainly approved for the treatment of the rheumatoid arthritis, where the second generation is used for the allographic purpose. Whereas the second generation belatacept is given by IV maintenance, and it is the first IV maintenance immunosuppressant. Dosage is usually given 2 phases. Initially, it is administered 4 times in a month. First month at a higher dose to build up drug level or steady state concentration, then decrease to once monthly dosage. After 4 months, the dosage is also further decreases. Monthly dosage may be beneficial in patients for whom medication compliance is a problem. Clearance of the belatacept is not affected by age, sex, race, renal, or hepatic functions. Therefore, it can be safe in the renal hepatic compromising patients. Belatacept increase the risk of the PTLD, particularly the central nervous system. Therefore, it is contained in patients who are seronegative to Epstein-Barr virus, a common cause of the PTLD. Another group of the drug is which is used for the maintenance therapy is the mTOR inhibitors, which inhibit the signaling 3 pathway, and the drugs are the sirolimus, and they are also now previously the rapamycin and the everolimus. So sirolimus, previously known as a rapamycin, therefore mTOR are the compounds which are related with this, and the everolimus inhibit the protein mTOR, blocking the signal transduction pathway activated by signal 3-way progression into the cell cycle, and T cell proliferation is subsequently prevented. mTOR inhibitors are commonly used in multi-drug regime, frequently to minimize the dose of the calcarein inhibitors and spare their renal toxicity adverse effect. Mechanism of action of the mTOR inhibitors: mammalian target of the rapamycin, sirolimus, previously also known as rapamycin, everolimus. They inhibit the PK-based protein, which can inhibit the mTOR, which is responsible for mTOR increase the translation of the selected messenger RNAs that promote transition from G1 to S phase of the cell cycle. And this sirolimus FKBP complex inhibit the mTOR, thereby inhibiting translation and causing T cell to arrest the G1 phase, which lead to the formation of the new T cells by inhibiting at the G1 level. And that's the mechanism of action of the mammalian target inhibitor cells, that's the sirolimus and the everolimus. mTOR, mammalian target of the rapamycin. Rapamycin is the old name of the sirolimus. Like the calcarein inhibitors, both the mTOR inhibitors are metabolized by the cytochrome 3A and are substrate to the P-glycoprotein and are subject to the numerous drug-drug interaction. Both agents require drug monitoring of the thorough concentration to optimize therapy and get the beneficial effect to the patient with the maximum adverse effect. Sirolimus has a longer half-life than the calcium inhibitors or everolimus. They are given a single dose daily. Anti-proliferation of the sirolimus is also available in cardiology, where sirolimus-coated stents are used to inhibit the stenosis of the blood vessels by reducing proliferation of the endothelial cells. So one of the use of the sirolimus along with the as an immunosuppressant, they are also used in the cardiology to coated the stents. Whereas the elements is also used in the oncology to treat many different types of the cancer, including breast cancer, renal cancers, and the neuroendocrine tumors. How the dose of the tumor treatments are much higher than those which use in the transplantation. There is another group of the drug is the anti-proliferative agent. Azathioprine also uses anti-cancer agent, whereas another is a mycophenolate. Both block the lymphocyte profile by inhibiting the nucleic acid synthesis. Azathioprine, first agent to achieve widespread use in organ transplantation. It's a product that is converted to first 6-mercaptopurine and then to the corresponding nucleotide analog thioinosinic acid. This analog is incorporated into the nucleic acid chain and block the further elongation of the DNA. There is a mycophenolate is a potent reversible non-competitive inhibitor of inosine monophosphate dehydrogenase, which block the de novo formation of the guanosine monophosphate. Because lymphocytes are unable to utilize the cleavage pathway of the nucleotide synthesis, therefore, mycophenolate effectively block T cells and B cell profile by eliminating de novo production of the guanosine monophosphate, and this is shown in this diagram that inosine monophosphate by mycophenolate inhibit the formation of inosine monophosphate dehydrogenase, which inhibit the formation of xanthosine monophosphate, and finally they block the formation of the guanine monophosphate rapidly, which is required for proliferation of T and B cells as a key precursor required for the nucleic acid synthesis. So that is a mechanism of the mycophenolate compound. These medications are used as an adjuvant immunosuppressant, primarily with a calcineurin inhibitor with or without corticosteroid. Our mycophenolate has largely replaced azathioprine in this role due to its improved safety and efficacy profile as compared to the azathioprine. The main dose limiting adverse effect of the azathioprine is the bone marrow suppression, whereas the allopurinol inhibits the metabolism of the azathioprine, therefore enhancing the adverse effect of the azathioprine, which is also used as a immunosuppressant for the management of the gout. Thus, co-administration of these allopurinol requires a significant reduction in the azothioprine dosage in the immunocompromising patients when both are used, allopurinol along the azathioprine. These drugs are the adjuvant immunosuppressant, primarily with the calcineurin inhibitor without corticosteroid. Mycophenolate is available in two forms as a product: mycophenolate mofetil, mycophenolic acid. Mycophenolate mofetil is rapidly hydrolyzed into the GIT to mycophenolic acid. Then mycophenolate by glucuronidation in the liver produces an inactive metabolite, but enterohepatic recirculation causes prolongation of the effect of these drugs. Mycophenolic acid. Mycophenolate is an enteric-coated tablet designed to theoretically reduce the GIT upset commonly experienced with the mycophenolate mofetil. Another drug commonly used drugs is the corticosteroids. First pharmacological agent to be used as an immunosuppressant, both in the transplantation and in the various autoimmune disorders. Now, still it is also used. They are still one of the mainstay of the attenuating the rejection episode for transplant. The most common agents are the prednisolone and the methylprednisolone. Where the corticosteroid prednisolone, prednisone, and the prednisolone are used for the autoimmune conditions. In transplantation, they are used in combination with the other immunosuppressant drugs. These corticosteroids are used to suppress acute rejection of the solid organ allograft or solid organ transplant and chronic graft versus host disease. In addition to, they are effective against the wide range of the autoimmune disease like the refractory rheumatoid arthritis, systemic lupus erythematosus, temporal arthritis, and the asthma. The exact mechanism is unclear, but it is said that they inhibit the T cell lymphocytes are most affected and inhibit the T lymphocytes. They are able to rapidly reduce the lymphocyte population by lysis or redistribution of the T lymphocytes. On entering the cell, they bind to the glucocorticoid receptors, and this complex passes into the nucleus and regulates the transcription of DNA. Use of the corticosteroid is associated with the numerous adverse effects like the diabetogenic, increase the glucose level, can cause the hypercholesteremia, can cause the cataract, increase the formation of the cataract, osteoporosis, hypertension with the prolonged use. Further prolonged use can cause the disturb the adrenal cortical axis. Further use can cause the moon shape or round shape of the face, deposition of the fat around the. This is a summary of the drugs which are used as a maintenance therapy. Like the azithromycin is anti-proliferogenic used in the salt organ transplant allograft. Petracept is a co-stimulation blockage used also into the organ transplant, solid organ transplant. Cyclosporin is a calcineurin inhibitor used in the organ solid transplant. Everolimus is a mTOR inhibitors. Well, these are the corticosteroids, while myoclonal anti-proliferative compounds used for the solid organ transplant allograft. Cellulomas and trilomas are the mTOR inhibitors, which is also used for solid organ transplant. So this is a summary, and this all lecture is prepared from the Lipin card. This all lecture is prepared from the Lipin card. So that was all about the lecture. Any question, if any student have? Any question, if any student have, then we go for the some BCQs. Any student, if they have any question, most welcome. Okay, if no question, then we go to some BCQs. First BCQ. A 44-year-old man who received a renal transplant 3 months ago is being maintained on tacrolimus, pyridoxine, and mycophenolate morphine is found to have increased creatinine level, means kidney problem, and a kidney biopsy indicates severe rejection. Which course of therapy would be appropriate? Either we increase the dose of the pyridoxine, A, treatment with the rapid anti-thymocyte globulin, we shift the drug treatment pattern, we change the drug pattern, treatment with the sirolimus, and treatment with the azathioprine. Answer of this is the B, because these drugs are mainly given for the maintenance therapy, whereas when the rejection occurs, we must start the acute therapy. Therefore, patient is appropriately undergoing the acute rejection of the kidney. The most effective treatment would be the administration of antibodies. Therefore, we use the rapid anti-thymocyte globulin, which are more safer as compared to the harsh antibodies globulin, more efficacious, less side effect. Increase the dose of the pyridoxine may have some effect, but would not be enough to treat the rejection. Sirolimus is used prophylactically with a cyclosporin to prevent the renal rejection, but is less effective than an episode occur, where the azathioprine has no benefit over the mycophenolate compound. Second question is, following immunosuppressive drugs combination should be avoided. Basilimex, betlacept, mycophenolate, and the prednisone. Or B, mycophenolate, morphine, tacrolimus, prednisone. Or tacrolimus, cyclosporin, and prednisone. Or the tacrolimus, sirolimus, and the answer of this is C, because tacrolimus and cyclosporin are both having the same mechanism of action, that is, they are inhibitor of the calcareum inhibitor, have the same mechanism. Therefore, in combination therapy, it is recommended that we should avoid the same group of the drugs to minimize the side effect, to give the maximum benefit to the patient. So answer of this is that avoid the tacrolimus combination with the cyclosporin. Avoid the tacrolimus combination with the cyclosporin because both have the same mechanism of action. Immunosuppressive drugs regime should work synergetically at different places in the T cell activation mechanism. Additionally, cyclosporin and tacrolimus are both extremely nephrotoxic and when used together would cause harm to the patient. So this should be avoided. One is the same mechanism of action, other with the both have the same toxicity, that is a nephrotoxicity. Therefore, chances of the renal toxicity will be increases, and we get the less benefit because their site of action is the same. So all of the combination are reasonable except combination of the calcareum inhibitors. Both. Which drug used to prevent allograft rejection can cause the hyperlipidemia? Basilimex, betlacept, mycophenolate, and the sirolimus. Answer of this is the sirolimus because sirolimus can cause the elevated cholesterol level, disturb the lipid profile. None of the other have effect on the lipid cholesterol level or the cholesterol level or triglyceride level. There are patients who are receiving the sirolimus can develop the elevated cholesterol level. Therefore, patient receiving this sirolimus should be monitored the liver function or checking of the liver functions. Which drug especially inhibit the calcareum in the activate T lymphocytes? Tacrolimus, sirolimus, and the basilimex. C, B, tacrolimus has a bind to the escape protein in turn inhibit the calcareum interference cascade, synthesized interleukin. Although basilimex also interfere with the T lymphocyte protein, it does not bind with the CD20. Whereas sirolimus also binding the FKBP but does not inhibit the calcareum myoclonic multiple excited immunosuppressed by inhibiting the inosine monophosphate dehydrogenase. So this was all about the immunosuppressant and all these questions of the BCQ. Patient taking the immunosuppressing drugs after renal transplant and patient develop the complaining of the facial hair growth, developing the facial hair growth and does not want to take the immunosuppressant due to the facial hair growth. Which drug is mainly responsible? As I told you in my lectures, switch cyclosporin to the tacrolimus. Cyclosporin is the main drug which can cause the hirsutism or facial hair growth. So answer of this is the switching of the cyclosporin to the tacrolimus because this drug is responsible for the growth of the hair in this patient, which can cause the refusal of the by the patient woman. Hello. Walaikum assalam. सर लेक्चर पे आउट हूँ बस ये थोड़ी देर में फारिग थी दासी हलो ठीक 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 है so mere appropriate drug in this case is the switching of the cyclosporin to the tacrolimus. Facial growth, hirsutism or exudative growth is a well-known adverse effect of cyclosporin. May patient experience dark, coarse facial or body hair growth while taking the cyclosporin. Therefore, switching of the cyclosporin to the tacrolimus would eliminate these adverse effects and keep the patient on the calcium inhibitor that is effective in preventing of the rejection. Myclophenate and the prednisone are not known to be cause the abnormal hair growth. Which immunosuppression medication avoid to need the therapeutic drug monitoring? Myclophenate, tacrolimus, cyclosporin, sirolimus. Whereas in this is myclophenate is the correct answer since there is no role of the for routine monitoring with this medication, whereas the other drugs can require the monitoring of the drugs because they act on the liver. So calcium inhibitors, cyclosporin, tacrolimus, and mTOR inhibitors, sirolimus and the everolimus require therapeutic drug monitoring in order to maximize efficacy, prevent rejection, and minimize toxicity. Whereas mycophenolate do not require the especially monitoring or care. There is a other question of which clinical situation these approved for immunosuppression with the sirolimus. So this was the answer is the D. And other BCQ is which statement is correct regarding the difference between induction immunosuppression and the maintenance immunosuppression. And question is the also the B, whereas a 30-year-old admit 3-month liver transplant and then decide to start the treatment with the anti-thymocyte globulin due to the rejection. Which additional drug therapy required? Answer is the D, whereas and this all thanks to Almighty Allah. Allah Pak bless it. This all was question, BC question taken from the Lipin card and all the lecture prepared from the Lipin cards. So now class is open for discussion. Any student have any question, most welcome.